Hello, good evening. Hello.
Hello, good evening.
Okay. Welcome to everyone. While waiting for the participant to come, let us start. So good evening, good afternoon, good morning, according to your time zone. So my name is Dr. Gloria Dushimirimana. I'm a surgical student at St. Paul Hospital Millennium Medical College, Ethiopia. I'm serving as Secretary and Public Relations Officer for Operating Room Global Ethiopian Chapter. It's with great honor to welcome you all to today's panel discussion organized by Operating Room Global Ethiopian Chapter under the powerful theme, Building Strong Surgical Team, Unity in Action. This event is more than just a discussion. It's a call for action, a symbol of our shared goals, a reflection of spirit of collaboration that's shaping the future of surgery across the borders. We are proud to be joined by our esteemed partners, Cameroonian Medical Student Association, Intuition Cameroon, and the Cameroon Nurses Association. Your presence reminds us that surgical care is not only built on skills and knowledge, but about teamwork, solidarity, mutual respect across all professionals, lines, and nations. In every operating room, whether in Addis Ababa, Yaoundé, or elsewhere, we know the truth. No one works alone. Surgeons, nurses, anesthetists, students, all supporting staff, we are all essential part of the same team, united by a single mission to save lives and uphold dignity. As we discuss challenges and solutions today, from training gaps to interprofessional communication, let us be bold, honest, and open to learning from one another. Let us remember that a strong surgical team is not only built on isolation, but unity in action through shared goals, shared struggles, and shared victories. Thank you, everyone who made this gathering possible. For your efforts is a testimony that we can achieve when we rise beyond boundaries, titles, and when we come together as the surgical community. So on behalf of TOJ Ethiopia, I thank each and every one of you to join us today and your commitment to better, safer, and more united surgical system in Africa and beyond. Welcome our panelists, welcome our guests, welcome our colleagues and friends. Let us start our today panel discussion. Thank you very much.
Thank you very much, Dr. Gloria, for that wonderful introduction. Can you all hear me, please?
Yes.
Yes,
we hear.
Thank you. I am Samuel Fodop, a medical doctor in training from Cameroon, and I currently serve as a fellow for the Operating Room Global. So without further ado, I'm going to be introducing our various our moderator first, then our various co-panelists. So I'll start with our moderator, Dr. Nigusie Tefera, who happens to be a distinguished clinical and public health expert with extensive experience in healthcare leadership, quality improvement, and patient safety. Currently serves as the Chief Clinical Officer at Debri Biran Comprehensive Specialized Hospital, a facility recognized with 3 consecutive Ethiopian Hospital Alliance for Quality Awards in Ethiopia. With a strong background in both clinical medicine and public health, Dr. Nigusi is Executive Committee member of the Operating Room Global Ethiopian chapter, and he has led numerous initiatives to strengthen healthcare systems, enhance evidence-based practices, and implement sustainable quality improvement models. He is a lead expert in infection prevention and control, and a trusted advisor in patient safety. Dr. Nigusi, if you're with us, kindly indicate. Are you with us?
Thank you very much, Mr. Simon. Thank you very much.
Okay, thank you very much. I'll move on to introducing each one of our panelists.
You are muted, I think.
Oh, it's muted. Okay, can you hear me now? Thank you. So I was introducing Professor Adeleye, who is a prominent and accomplished professional who holds the esteemed position of professor and consultant in the Department of Community Health at the School of Medicine, University of Benin. That's at the University of Benin Teaching Hospital, Nigeria. His extensive background and expertise in public health and community medicine mark him as a beacon of knowledge in the field. Having served as the former deputy chairman of the Medical Advisory Committee at the University of Benin Teaching Hospital, Prof. Adeleye's dedication to ethical healthcare practices is highly commendable. His contributions have made a lasting impact on healthcare ethics within his institution. His influence transcends borders as he is actively engaged with the West African Bioethics Training Program in Ibadan, Nigeria. His commitment to education and ethics is further reflected in his role as the head of Education Technical Working Group and member of the National Bioethics Committee of Nigeria. He is currently the director of the Center for Artificial Intelligence Development at the University of Benin, Nigeria. Professor Adeleye, it's a true honor to have you in our midst. If you're with us, kindly indicate.
Thank you very much. I appreciate you. I'm glad to be here.
Thank you very much, sir. It's an honor to have you. Moving on to our next panelist, who is no other person than Dr. Leonid Daya, right from Cameroon. If you're from Cameroon, kindly make some noise in the chat box. Dr. Daya is a practicing anesthesiologist based in Cameroon, who earned her medical degree from the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé 1. She currently serves at the Soa District Hospital. She's very passionate about global health, global surgery, medical education through simulation, and patient safety. She is an active member of the Cameroonian Society of Anesthesia and Critical Care, where she contributes to advancing anesthetic practices nationally. Dr. Daya is deeply committed to improving healthcare outcomes and strengthening surgical systems within her community. Dr. Daya, it's an honor to have you in our midst. Bonsoir, Dr. Daya.
Bonsoir. Merci pour l'invitation.
Okay, so moving on to our next panelist. Next up, we have Professor Larry Apoku, who is an associate professor of surgery based at the Muhimbili National Hospital in Dar es Salaam, Tanzania. He plays a key role in national and regional surgical system strengthening as a member of the National Surgical, Obstetric and Anesthesia Plan Technical Working Group, the SADC Technical Working Group, and as the COSEXA country representative of Tanzania. COSEXA stands for the College of Southern, East and Central African Surgeons. Professor Akoko is actively engaged in advancing surgical education, capacity building, and policy implementation across sub-Saharan Africa. Professor Akoko, it's a pleasure to have you in our midst. If Prof. Akoko is here, would you please indicate? Okay, so while waiting for Professor Akoko, I'm going to introduce our next speaker. Our next speaker is Mrs. Kie Mary Ann, still from Cameroon. Mrs. Kie Mary Ann is a dedicated and accomplished nurse leader with over 12 years of clinical experience. She holds a Bachelor of Nursing Sciences and a master's degree in laparoscopic surgery. She currently serves as the unit head of the operating room at the Bamenda Regional Hospital. She leads a multidisciplinary surgical team comprising of surgeons, anesthesiologists, anesthetists, and nurses. As a respected female leader in a traditionally male-dominated space, she has cultivated a strong culture of unity, mutual respect, and collaborative practice within her team. Beyond her clinical role, Mrs. Kie is actively involved in mentoring the next generation of healthcare professionals, contributing to the training of medical students and nursing interns from institutions across Cameroon. Her experiences and insights promise to be both inspiring and instructive during this panel discussion. And as a student who is being trained under her watch, I can assure you that she's a true leader, and I look forward to learning from her. She's currently having some issues joining, but she will be with us very shortly. Next up, we have Dr. Razak Khan, who is an last panelist for this session. He has an illustrious career spanning 19 years in healthcare administration and research, and brings a wealth of knowledge and expertise to our audience. Dr. Khan embarked on his journey in healthcare at the prestigious Aga Khan University Hospital in 2006, where he began as an operating room technologist. Throughout his career, he has contributed significantly to various healthcare institutions, including the Dole University Hospital, Al-Kimat Foundation, and MMIH, showcasing his dedication to advancing healthcare delivery. Having pursued a PhD fellowship and completed an MBA and Masters of Science in Healthcare Management from IBT, Dr. Khan's commitment to excellence is evident in his certifications, holding the esteemed titles of Six Sigma Black and Green Belt Certified Health Quality Professional. That demands a round of applause, please. He has also actively pursued further education through numerous training courses, ensuring he remains at the forefront of healthcare innovation. Currently serving as a senior administrator at Childlife Foundation and concurrently as a research scholar at Aga Khan University, Dr. Khan continues to make significant contributions to healthcare practice and research. Furthermore, his leadership extends to his role as the chairman of the Operating Room Global Pakistan chapter, where he plays a pivotal role in advancing the mission of the Operating Room Global. Dr. Khan, we are very delighted to have you in our midst. If you can hear us, kindly indicate.
Thank you, Samuel, for this wonderful introduction. I'm glad to be a part of this wonderful discussion. Thank you.
Thank you too for being with us. So I'm going to give the floor to Dr. Tifira, Dr. Negisi Tifira, who is our moderator for this session. Over to you, Dr. Tifira.
Thank you very much, Sir Samuel, for your nice presentation. Those credible panelists, really impressive bio profile. Thank you very much. And the panel discussion has two rounds. The first round is it is just the first round focuses on the perspectives of perspectives on the surgical team dynamics and the practice. And the second round is just policy, mentorship, and surgical team empowerment. For the interest of time, each panelist will take 3 up to 4 minutes. And finally, we will have discussion questions from the participants. Welcome again. And the first question for the first round is for Professor Omokuha. And the question for you is, what systems, label frameworks, or policies could help embed a culture of collaboration among surgical teams across African health institutions? And the second question is this for Professor Larry. How do you balance your role as a mentor with maintaining operative efficiency, especially under high pressure surgical conditions? And the third question is for Dr. Leon. Could you share that? Could you share? Sorry. The second question. Let me revise the questions again. Sorry. The first question is for Professor, as stated. It says, let me repeat the question again. In your view, how do public health structures and community medicine approaches influence the functionality and unity of surgical teams in hospital settings? It is for Professor Omokuha. And for the second question is for Professor Larry. Drawing from your surgical experience, what key elements either strengthen or undermine cohesion among members of the surgical team? And the third question for the first round for Dr. Leon, from the anesthesiology standpoint, from anesthesiology perspective, what contributions are essential to fostering safe collaborative teamwork in the operating room? The fourth question for Mr. Sunday. What proven strategies have you used to address and manage interdisciplinary tensions or breakdowns in the OR setting? The fifth for Mr. Kiam. How does mid-level leadership at the unit level influence day-to-day team harmony and motivation in surgical environment? And the last question is for Dr. Raza. From your role, what team building aspects are frequently overlooked but critical for efficient OR performances? These are the questions for the first round. So let the panelists start your answer. Let you reflect on the questions. You have 3 to 4 minutes. Thank you. Welcome, Professor Omokuha.
All right, thank you very much for bringing up this topic. I thank the organizers for inviting me. I take the question to address the issues. I hope I heard correctly. In your view, how do public health structures and community medicine approaches influence the functionality and unity of surgical team in hospital settings? Of course, the theme begets the question, and it's a very appropriate question. Public health and community medicine operates at all levels of healthcare. And where the surgical team exists, you would have a public health team at least at the tertiary healthcare level. And I'm going to speak basically from that perspective. And then we can share on how that dovetails all the way down to the primary healthcare level. Fundamentally, let us remember that team building or surgical teams in hospitals describe management systems. It's a surgical management system, and health management is a component of public health and community medicine. One of the ways that the approaches of public health deal with unity and the functionality of surgical teams is to measure using appropriate management indicators, the extent to which there is team collaboration, team communication, and possibly areas in which there is breakdown in that communication. We also measure compliance levels and determine whether there is strict disciplinary compliance within the different settings. Of course, the expectations of the inputs of a technologist is different from that of an anesthetist, different from that of the surgeon or the surgical nurse, and so on and so forth. One way in which we have harmonized this, particularly in my practice, is to help the hospital to develop standard operating procedures. Standard operating procedures. So whereas each profession has its approach to carrying out a procedure, it is important to harmonize the different approaches that the different professions have in a manner that will provide maximum benefit for the patient by also promoting harmony in communication between the different professions. This management approach enables best practices. It promotes interprofessional communication to strengthen one another. If there's deficiency on one side, somebody can draw attention and say, hey, hello. And then maybe that way there's a signal that the person knows that, oh, you're making an error somewhere. The surgeon can ask, please check the oxygen. The anesthetist can make adjustments and ask, do you need any additional intervention? And communication then takes place very smoothly. So that way there is respect and then there is value delivery because of harmony of communication and compliance with standard operating procedures. Thank you.
Thank you very much. The second presenter, Dr. Leo. It is time for the second presenter. Dr. Leon.
Oh, it's me.
Yeah.
Okay, sorry. Thank you for giving me this opportunity to speak about operating room environment. The question is contributions which are essential.
Let me, okay. May I remind you your question is?
Sorry?
Okay, may I remind you your question is from the anesthesiology perspective or standpoints, what contributions are essential to fostering safe collaborative teamwork in the operating room?
Okay, thank you. I think Professor Mokwa already started to give a shape for an answer, and I really agree with what he says. We need to talk about harmonize different professions, standard operation. Yes, that's really important. It's really important because it makes sure everybody is at the same level of understanding of what is going on in the operating room. We need skilled staff, well trained and everything, but if each members of the team knows that for this case I should behave like this, I think it will be smoother in the operating room. But we should also think about prioritizing patient safety above all. I mean, it's a vision. Everybody in the operating room, when he comes in the morning, should think about patient safety. And patient safety is about communication, as we both say. It's about communication, clear and effective communication, anticipation, preparation. And it may be difficult because we have, among the team, we have diverse behavioral, cultural aspects we should manage to be very, to be a cohesive team, and conflict may arise. So when we have evidence-based tools like protocols, checklists, harmonized operative tools, I think it really helps. And another thing, it's in the operating room, we need a strong leadership. A strong leadership may be taken by, usually it's the surgeon. That role is for the surgeon, but the anesthetist can also take the lead. The operating room nurse should also take the lead. And everybody in the room should be able to understand that the lead is telling us to go this way, we should go this way. If the patient safety is ensured. Yes, so I think those are the main points. Prioritizing patient safety, having a strong leadership in the operating room, in the unit or in the hospital. And at the end, I think with those three elements, we can have a very collaborative teamwork in the operating room. I hope I understood the question and that you understood what I said. I'm a French speaker.
It is time for Professor Larry. Okay,
Yes,
let it be. Okay.
yeah. I'm sorry I joined late. Did I have a specific question, or I'm just to address the whole team? Sorry, I can't hear you.
Professor.
I can't hear. Yes, I didn't hear you. Yes, come again.
Okay, sorry. Your question is, drawing from your surgical experience, what key elements either strengthen or undermine cohesion among members of the surgical team? What affects the team spirit negatively or positively?
Okay, thank you very much. I think first and foremost, it is important for us as surgical community to know that the scalpel is just a pinch of surgery, and the whole team would make the whole difference. So typically, a surgical patient that we meet comes from the community and goes back to the community, and we are just in the hospital. So I want to address this team concept from within the hospital, and I'm going to ignore what happens in the community. So many a times I think there are teams that stay together, and there is one person in the team who only comes when he wants to do that surgery. And many a times this one person is the surgeon and wants to think is more important than others. And because no prior goals or communication has been set in advance, so that each member of the team knows their roles and their limits. So when that happens, then there is that breakdown in team spirit. When the surgeons start feeling like our common joke with anesthesia colleagues, that they learn anesthesia very shorter time, and the longest part of their time, they learn how to cancel our cases. So when we don't have a commonality, how to discuss complex situations, how to come to an agreement, what are the work schedule hours, then we will clash in time. My surgeons locally last week were complaining that everybody is being paid extra duty when they work beyond working hours and not the surgeon. And I asked them, why do you think it is so? And they said, I think they don't like us as surgeons. And I said, no, the administrators feel like the surgeon did not manage time well. So they are punishing you by not giving you extra duty so that next time you plan well. So next time when they planned well, the list ended at noon. And there are 5 more hours of operation left with theater going underutilized because surgeon is saying, okay, they're not giving me extra duty. Now I will only have 1 case a day and call it a day. So when that communication is failing, understanding why cases are running late, when everybody started on time, and understanding that patients need to be cleared, that communication breakdown. So technically it goes down to communication. Anything that I would mention is communication and not having clarity on who is the team leader, who is making decision, how do you share the risk of the patient that you are bringing on the table? How do you manage time? How do you manage when you are going to be late? Who is going to be compensated? How much are they willing? Was it anticipated? So elsewhere, people work with fixed teams where you have your fixed nursing team, your fixed anesthesia team, and once in a while, they go out for a drink to just lower down the tensions that have been building because they are unavoidable. You will always have tensions when operating, and you need to breathe out and say that nothing was really intentional. Everything was just for the better of the patient that we are serving, that we might have stepped on one another's roles just to make sure that things are working. So it is always good to debrief at the end of the surgery to make sure that any miscommunication that took place is sorted. So you don't need to actually mention that there was a problem. You just need to shake hands and say that I think we have done a good job today, even if you feel there was some tension. But that handshaking is always missing. People finish a case and they're not talking to each other. And I don't want to think of the unimaginable, but the person who will suffer is always the patient. So debriefing, communication, leadership, all this, when they miss, then there will be breakdown in that teamwork. So I think the surgeons are taught surgeon as a team leader, but they should also be taught that they're working within a complex environment. And the other team members also, the anesthesiologists, the nurses, the biomedical, the cleaner. So in the morning when people meet, people don't discuss the concern. I have a list of 4 patients and I feel like I can finish it, but the other part of the team feel like it's a longer list. So we need to communicate and see how we are going to make sure that we finish our 4 cases, or whether we need to reconsider the length of our list when you are not planning it together. In other places, they plan it together and they decide when are you taking the last case and things like that. So in my experience as a surgeon over 15 years, we hardly communicate So one team will be having their own objectives. They want to finish early. This one want to stay longer because it's having more patients in the ward. And so that lack of constant teams that work together is also a big problem, especially when you are in complex hospital like where I'm operating at a national hospital. When you are in a smaller hospital, it's less tense. People tend to only be doing emergencies, so they work together, they stay together. But the moment complexities increase in surgery, I think there is more need for teams to communicate and understand that the cases will be long. And the management need to also understand how to make sure that everybody in the team is rewarded for the work that they're doing equally. If long cases will not be compensated, everybody is not compensated, and they should not occur frequently. Yeah, so I think what I'm trying to drive home here is communication is always very important. And it is always very important for the surgeon to maintain an open communication with the rest of the team members on expectations of the day, expectations of the team. The preparation should be thorough. When you say you don't need blood, then suddenly you need blood and nobody is prepared to bring that blood when the blood bank is not within the operating theater. All this require proper communication on who will be doing what. And I think the WHO checklist, as simple as we might think it is, sometimes people operate without knowing each other, even by name. So when things turn hot and you don't know how to address the people you are operating with because you don't know their names, you did not introduce each other, you are new to each other. So I think there are smaller steps, but when we miss them, then we break this communication. Thank you. Hello.
Yes. Good evening, everybody. I guess we're hearing me. Hello.
Hello.
Yes, I can hear you.
Okay. All right. Good evening, everybody. Once again, it's my pleasure being able to talk to us again today after the Nigerian version, and I look forward to us having to meet again in Rwanda. However, building strong surgical team, I think is key, and having spent about 30 years or thereabout in the operating room, I think my experiences are what I would be discussing. I quite agree with the last three speakers on what they've said, their thinking, and what they've come to conclude on. However, I like to say at this point that the problems seems to be coming from three key areas. First is miscommunication. The second is misconception following misunderstanding. These three comes together and tend to separate the different professionals within the operating room. Just like has been mentioned, the operating room, of course, is a conglomeration of professionals. The anesthetists, the surgeons, the technicians, the operating room practitioners, surgeons assistants, in terms of fluoroscopy, the radiographers. So you have a bunch of people coming together to perform that act, science and art called surgery. However, from all that have been said, I've witnessed, yes, a few hitches in the operating room, which affected personnel and ultimately affecting the patient who was at the receiving end. Over time, I have looked at these issues again and again and have come to conclude that, again, haven't tried it and they worked, hence I'm talking from experience, is one, establishing communication channels. different things happens in the operating room. The last speaker took his time to enumerate the series of issues that comes up or that could come up. We didn't plan for this, we didn't prepare properly. The other guys do not really know what the surgeon is actually going to do. The anesthesia guys did not know to what extent the surgeon was going to go. So middle of the case, you need blood, and we start running up and down. So to this extent, we've just provided a solution that I also have found valuable, which is debriefing. When people working together have the opportunity to talk, to discuss what they want to do, how they plan to carry out these activities, plus at the end of carrying the activities, what were our shortcomings. The last speaker also talked about the use of surgical checklists. Beautiful. That simple act of introducing surgical team members starts the day and the procedure with that fraternity. We tend to know each other. Sometimes by mentioning names, they may even make the other person to laugh and all that. So we tend to start the case in that high spirit. So having regular meetings, like I said, have helped. Establishing communication pattern. How do I mean? Where the most junior person in the operating room, junior in terms of professional inclination, not aggregate now, has a problem, how does he channel it? Speak directly, talk to his senior who takes it up, goes to the manager of the theater. You know, all these have when defined, have had a long way to go in preventing and making the theater team bond together. The second thing is Dr. Prof actually mentioned that protocols and procedures are actually both intra-disciplinary and interdisciplinary. Now, every member of the intra knows their protocol, but the other team does not know. So it became necessary to devise a means to have interdisciplinary protocols and procedures where the team meets, reviews the different protocols in the different intra to have a unified inter, which everybody obeys, and at the end of the day, there is harmony. Teamwork and collaboration have also proven to be a key strategy to building a strong surgical team and members. These have been promoted by joint meeting sessions. Yes, the nurses will have their meeting, the anesthesia guys will have their meeting, but having the team to meet together from time to time have proven to be a good strategy. Now, trainings have also been identified as one of the tools which improves efficiency and effectiveness. To this extent, professionals do trainings intra, but when we do interdepartmental trainings, interprofessional trainings, where the different teams comes together to participate in a training, it tends to bond them together, and emphasis now is on interdisciplinary achievement rather than intradisciplinary achievement. So if everybody in the team sees a successful surgery as an outcome that is laudable to the team, everybody as a member tends to put in their best. Lastly, there will always be confusion. There will always be reasons why people would disagree and may not agree, but that has to be dealt with. So early preparation prevents poor performance. Where there is going to be a problem, first we'll define how do we escalate potential issues. So if we have a defined pathway for escalation, it becomes very simple. So a matter that is brewing would follow that escalation process, and before it becomes something else, it's dealt with. But where there are no defined escalation processes, you then find out that things happen, they are kept, and at the end of the day, by the time it comes out, it becomes a big problem. Now, when things are escalated and people work together, The ingredient necessary now for the bonding would then be respect for each other. Now, if you follow the trend, you will find out that one thing that have been mentioned repeatedly and is noticed in everything I've said would be working together, training together, working together, doing lectures together, participating in procedures together. Everything now goes together. Each person sees what the other person does, tends to understand what the other person does. So at the end of the day, this misconception is removed, the misunderstanding is removed, and at the end of the day, whatever miscommunication is now in such a situation where it will be properly communicated. So building a strong surgical team, in my opinion, and coming from my experience, is borders around communication. The way and manner we communicate will determine the reaction of the next person. If you take yourself as the super leader, as we know the way it is in the operating team, democracy is then what we need to deal with things. And through meetings and trainings, this can be done. So I think this topic is a key topic that most centers really need to imbibe. And at the end of the day, I'm sure we will be better for it. Thank you very much.
Okay. Just your turn is, or your question is, how does, it is for Miss K. How does mid-level leadership as a unit level influence day-to-day team harmony and motivate in surgical environment? You are at the OR nurse unit head. What's the middle? Okay. Miss K, is it audible for you? Okay. For the interest of time, let's proceed for the last speaker for this round, for Dr. Raza. From your role, what team building aspects are frequently overlooked but critical for the efficient OR performance?
Thank you. So I would like to answer this question in two parts. The first one, I would like to describe the role of surgical technologists in the operating room. So the OR technologists or the surgical technologists are the one who first to enter in the operating room and last to leave the OR. And they are the silent enabler of the OR efficiency. They coordinate entire OR things, instruments, surgical staff, medications, all these things, and they have the direct impact on team flow. But the one of unfortunate thing, they are often overlooked or excluded from the decision making. So they usually we don't take the input from them in the decision makers in the long-term plannings. So the integration of the OR technologies in the decision making, I think this is the fix. So we can take them as the team member of OR. They are not just the instrument handler, but they are the reading of entire operating room. They knows the everything of OR. Like the surgeon came for the surgery, they own the patients, and after the surgery, after the respective patient, they leave the OR. Anesthetist came for the anesthesia, anesthetize the patient, perform the procedure, and then leave. But the OR technician own the entire room. They know each and everything in the room. So for the part of the question, I feel that the overlooked thing, that is the inclusion of OR team as a team member in the pre-booking briefing, in the time of the surgical planning, surgical cases. So they should be included in the formal case planning and the hurdles meeting. So at this stage, their feedbacks, their communication might help us for the OR efficiency, for the patient safety, for the case planning, and the challenges which comes during the surgery, like Dr. Tunde and the other team members miss the communication, the miscommunication, the misconception, which is often found in the OR. Um, they can be prevented. And the second most thing that I would stress out, that is the recognition of non-verbal coordination. In the OR, most of our team members has used the communication through non-verbal coordination, non-verbal clues. Like the surgeon is performing the surgery, but the OR technologist should know, should focus on the next move of the surgeon. Before they ask the name of the instrument, they get ready the instrument, the next step, and they plan. So the one thing that is inclusion in the case planning, and the second one in the recognition, in the non-verbal coordination, um, and the one of another most thing which discussed earlier, that this is the rule clarity. Every member should know their role, um, their scope of work, and every member should be mutually respected in the OR, because the efficiency breaks down when the team isn't clear on who does what is the role of which, and the OR environment is a highly pressure environment, um, because they are dealing with the life of the humans. So that is why it is encouraged, we encouraging the rule awareness across the hierarchy, um, like from the junior team member to the senior team member, from surgeon to the OR technologist. Every member should have the clear communication about the rule. And the last thing, that there should be a mechanism of feedback from the each and every member after the surgery, before the surgery, into the surgery. If any event happened, the team should sit down and think, do a root cause analysis. What happened? How it happened? How can we prevent it in the future? And how can we increase or efficiency, the team coordination, the team communication? So all these are, I think, the critical parts of the OR. Thank you.
Thank you very much, Dr. Kaza. Let's give the chance for Ms. Khan. I think come back to the connection. Mr. Khan, am I audible? Your question is, how does mid-level leadership at the unit level influence day-to-day team harmony and motivation in surgical environment? Okay, welcome. Okay, please unmute your.
Hello? Can you hear me?
You are audible, Mr. Khan.
Yes.
Good evening, everyone.
Dominic.
Yeah, but this Marianne, I think my question is, can you repeat my question again, please? And yeah. Ooh.
Okay, how does mid-level leadership at the unit level influence day-to-day team harmony and motivation in surgical environment? As OR nurse head, what's the mid-level leadership, how the mid-level leadership influence day-to-day team harmony, motivation and motivation in surgical team?
Okay, thank you. Thank you for the question. I'll just go straight to the point. I've been serving in the theater as a unit head for close to like 10 years, and I've been in practicing for 13 years. So like the role in harmony, the first thing I would say is effective communication, and which nearly all the other members, they have talked about it, like facilitates open communication in the unit by providing opportunities like staff concern, clarifying expectations, and resolving conflict in the unit. And the next point would be being a role model. You have to be a role model, like what you preach, set a tone for professional behavior, respect and empathy, promoting a positive team culture. And I think the next point will be encouraging a sense of unity and cooperation among team members at all levels by breaking barriers that exist between different staff, from cleaners to surgeons to social events, can be a great avenue to achieve this. And then the influence of motivation. The first thing I'll talk about would be like recognition and feedback. Regular feedback and recognition on the activities of the staff can boost moral and motivation. Empowerment, like training staff and dedicate tasks and provide autonomy to staff. That's most of the things that we do according to their abilities. This will increase a sense of ownership and will also motivate the staff. Support and develop, like providing opportunities for growth and development. That is motivating the team members to improve their skills. Encouraging, even sponsor participation, training, workshop. You can like work
I think
with other.
the connection has gone.
Hello?
Mr. Okay.
Can you hear me? And then on the impact, okay. The impact on the surgical environment will be like improving the patient care, and a motivated team work in harmony can lead to better patient management and the outcome and satisfaction of that patient. Reduce stress, that is positive team dynamics. And effective leadership can also reduce stress and burnout among team members. Increase efficiency. A good team leader can work more efficiently, streamlining processes and improving productivity. And then if you want to take now like all of this putting together, considering the cleaner, the anesthesiologists, the surgeons, everybody involved in the team, you see that they will be motivated and the outcome of these patients will really be positive. I think for that question, that is what I have for now to say. Thank you. Hello?
I think he's having network issues. Maybe we just give 2 minutes for him to reconnect. Thank you.
Hello? The network is not the best.
We can't hear you. We can't hear you.
Okay, all right. You can hear me. I was saying that putting all what I've said together, it will like improve on the outcome of our patient, you know, and then you also reduce burnout, and we make sure that in the surgical team we consider even the cleaner. We respect each other. Everybody, the cleaner, the surgeon, the anesthetists, the circulating nurses, all what they put together in the theater is very important. And I think respecting any other person's position is going to bring out a positive outcome of our patient.
Thank you very much. It is for the interest of time. Sorry, internet connection. Sorry for the inconvenience. Almost the first round is already finished. Let's proceed to the second round. Facilitators, please take note that summarize the question from the chat box, and finally we'll discuss or we'll address to the respected presenters. The second round, it is on regarding policy, mentorship, and team empowerment. The first question is, it is for Professor Amukia. Regarding policy, mentorship, and team building, surgical team building, and team empowerment, what systems, level frameworks, or policies could help embed a culture of collaboration among surgical teams across Africa health institutions?
All right, thank you very much.
I'm Professor.
I'm with you. I heard you clearly, and I hope you can hear me clearly. All right, so thank you. That's a very apt question because many of the things we're advocating for by way of this program are policy-driven and systems-driven. The frameworks need to work in line with our desirable objective. So how do these systems operate, and what are they? Do they even exist across Africa health institutions? And I dare say, do they even exist in global or other continental health institutions, or the systems that drive them? I must say that to the extent that I know, they hardly exist, not just in Africa, but anywhere on earth. And let me quickly say here, this is where TORG has distinguished itself, is the first of its kind, and perhaps the only one of its kind, the operating room global, that brings everyone under one umbrella. That is the spirit of collaboration. Systems level frameworks or policies, of course, could help to embed a culture. And remember, whenever we talk about culture, it's about human behavior. There's a limit to which policies alone can do that. In fact, it will be better using management language for it to be a bottom-up approach. That is, that the practice already exists, and that practice promotes the evolution or the emergence of the policies and frameworks that we're talking about, rather than a top-down approach. The absence of that top-down approach is what has necessitated and provided the opportunity for TORG to excellently fill that gap. And happily, it's happening at a global level. Africa is gaining from it. So what are these frameworks? It is a framework in which we should be able to, within such a framework where it exists, identify the following components. Number one, professional training. From the very basic level, from the point of training of a surgeon to medical school, the training of a health assistant assigned to the theater, to a surgical nurse, and so on and so forth, the idea of collaboration must be instilled. And that means that the curriculum itself must emphasize the importance and the need for collaboration, including how the collaboration works. Secondly, accreditation exercises for institutions should pay attention to the issue of collaboration. Accreditation teams should be able to ask questions like, to what extent is collaboration taking place here? The scoring system should be developed to assess the level of collaboration. Even if the scoring is essentially subjective, it's fine. The important thing is that we are measuring and that over time we're experiencing improvement. In-house, we can have system evaluation or even clinical audits in which there is audit of the system within the operating theater. People, participants, that is, members of the surgical team or the operating room team, are able to measure and express the extent to which they believe collaboration is taking place in their team and how collaboration can improve. Again, collaboration should go through all systems. I was happy to hear an earlier speaker make this point. And I had it in mind that I was going to emphasize, but I'll reduce it because he has explained it very well. Pre-operative, intra-operative, and post-operative phases, there should be collaboration. We often talk of the surgical team, the nursing surgical team, the anesthetic team. These teams tend to exist on parallel lines. We should begin to talk of cross-professional teams so that way there will be unavoidable collaboration. How does collaboration happen? It starts with communication. It starts with understanding the expectations of others. It starts with the decision-making about patients. It starts with how decisions then go ahead into implementation and how outcomes are measured. So all of these need to be there and instilled into policy and frameworks. Again, continuous training is absolutely important. Seminars, department operating room unit seminars that go across disciplines, workshops, even play role plays, and even national conferences, international discussions like what we're having right now. All of these can play very strong roles in promoting collaboration as a matter of system-level frameworks or policy. We can also have a deliberate incorporation of emotional intelligence, collaboration related to research. In other words, research should be able to capture team members whose training makes provision for contribution to research. And even if it's just the publication of clinical outputs or clinical outcomes of patients, the contributions of all team members must always be highlighted, especially in the publications of the hospital or the health facility involved. Then we should have bodies like this set up. It would just be wonderful if we could have other forms of operating room or surgical team organizations at African level, national levels, sub-regional levels, even within local and state levels, to have such arrangements. With that happening, both at the advocacy level and theater practice level, I believe that policies and other systems level frameworks can be very greatly promoted. For want of time, I'll stop here. Thank you very much. Are we together?
Okay, thank you. Thank you, Professor. And the second speaker is Professor Larry. Your question in policy mentorship and team empowerment, it will be, how do you balance your role as a mentor with maintaining operative efficiency, especially under high pressure surgical conditions? Professor Larry.
Yeah, thank you so much. A tough question. How to balance mentorship. Normally, I don't know whether I would be able to mentor the opposite team. Normally, mentorship works within people who share commonality, like I would mentor a young surgeon. And from that perspective, in my mentorship, I'll be taking them again through the same things that we have covered: communication, team building, and things like that. And they are built when they are still learning to be surgeons. Yeah, because that's when you try to water down the egos of trying to think that they can do everything in theater. So normally there is this with the boss. I've seen it, a question in the dashboard. And I try to tell my young surgeons that there is no boss. Boss is not a proper English, because everybody is a boss in this area. Even the attendant is the boss in the cleaning, because you will not operate in a dirty room. So normally I tell them there's a need to assume leadership and not bossy. Leadership is making sure that everybody is informed on what is going to happen and how it will happen, and when crisis occur, what will take place. So the mentorship should always focus around trying to put everybody in their roles. So trying to tell the surgeon that the only thing you have control about is the knife, and this is not the only thing about the whole of the surgery. There'll be anesthesia, there'll be the nurse on the instrument, and you need to learn from them. So they need to understand that learning will take place from multiple directives, and they will not only be from the person they are sharing their skills with, not from the surgeon. If you are a nurse, you are not learning from the nurse only, you are also learning from the surgeon. And all of you are learning from anesthesia. Everybody in the team should be able to understand what the other team is doing, not necessarily should be able to do what the other team is doing, but they should be able to understand the other team's perspective of doing things. So in a nutshell, that's what my mentorship would focus on: how to be a team leader. A leader is not a boss. A leader is just somebody who leads. And all of us in the operating room will be leading their own way and their own sides of profession. But at the end of the day, there's a common team leader, not a boss in the theater. So leadership is very important to be taught. And addressing conflicts, I found it very important to teach the personalities that they would meet in the operating room and how to focus on why they are in the operating room in the first place, and try to avoid things that would bring conflicts during surgery. And I've just found it very important for the young surgeons in the making to understand how to navigate conflicts. Conflicts will occur with the cancellation of cases. And I would always say, you're not the last person. Inform the next in line. And even when you are senior and your colleagues are wanting to cancel a case, try to understand their perspective also. There will always be another patient to be taken. So don't spend more time arguing, because that kills team spirit. And finally, I think knowing your limits is a very important aspect in mentorship. Knowing what you can achieve and what you cannot achieve within the team that you have is very important. So I don't know whether I've addressed that question in the way it was expected, but that's my feeling on mentorship and building the future surgeons who would work together with other colleagues as team in the operating room. Thank you.
Thank you, Professor, for your nice presentation. And the third, it is for turn for Dr. Leon. Regarding policy mentorship and team empowerment, what or could you share a specific case where a well-coordinated, unified team response made a critical difference during an intraoperative crisis? Or what is your experience that you may encounter in operation room or any surgical procedures, any case or any experience that you want to share, and how do you manage, how do you handle that crisis? Dr. Liam.
Well, thank you. As talking about experiences, I think as a young consultant, I didn't really have some situation I can call a crisis. But during my internship, I experienced few of them. The one I remember the most was an ENT case, and the patient was a young patient with a cardiac comorbidity. And during the surgery, he had a cardiac arrest. In fact, in the room, the anesthesiologist was not in because he had to run among many rooms, 3 to 4 rooms, and she was not in during when we noticed the cardiac arrest. So the nurse anesthetist told the surgeon, "We have a problem," and everybody in the room, there was music and everything, and "We have a problem, please stop." And the surgeon just stopped. And that was very amazing. The way he stopped was very impressive. So he understood that the nurse is calling for help. And he just starts the cardiac massage. So we could resuscitate the patient and end the surgery. That was my first time I experienced a cardiac arrest in the operating room during the surgery, and seeing how people were moving. The anesthesiologist just came back, the surgeon was doing the massage, the medical students were in a corner, and everybody was just like knowing what they had to do. And it was really a good experience for me. And I think that's cardiac arrest is the most powerful experience in an operating room. And once we know how to manage this type of crisis, I think we can be able to manage anything else. And the massage was being done by the surgeon and his helper. I don't know if you say that in English. And the helper, the second surgeon, we relay him. I don't know how to say that. So it was between the surgeon part, they were doing the massage, and the anesthesiologists were managing medication and other stuff. So I think that's a typical experience about managing team communication, role sharing. The surgeon was not just the surgeon, he had a response to, he understood there was a price and he didn't took time to respond or to get involved. So that's the main experience I faced, and it was long time ago. But as a consultant, minor things like goals counting that we could manage. doing a surgery. So I think whether it's a heart crisis like a cardiac arrest, or let's say a minor issue like dose counting, I think communication comes. We always talk about communication, role sharing, trust, and respect of every member of the team. So that's what I can say. Thank you.
Hello? Hello?
I can hear you.
Hello? All right, okay. From the perioperative perspective, how would the perioperative nurse help in instituting a topic of concern in the operating room? In agreement with Prof, I think it should start from the training institutions. Today's curriculum tends not to emphasize key social issues. First is collaboration. The word collaboration may be as simple as we see it, but when it is not properly understood, in the midst of situations, reactions tend to further make things not work. We don't see the need to collaborate. And collaboration haven't been identified. The other issue that needs to be inculcated or incorporated into our curriculum, especially at the point of training, is emotional intelligence. There will always be issues in the operating room. It's said that even there's this saying that says the tongue and the teeth both are in the mouth, but for reasons we cannot explain, the tongue is beaten by the tongue, by the teeth, even if it's not deliberate. So to that extent, it simply means that there will be issues that would come up from time to time in the operating room. But how we tend to handle these issues now becomes the real issue. Beyond that, we keep talking about team building. This is something we've mentioned over and over again. We need to build teams. When there is team and the team is actually a team, we tend to have efficiency or is received or rubs off on both the patient and the entire health team, particularly in this case, the surgical team members. So the Nursing and Midwifery Council of Nigeria, yes, and maybe all other people would be encouraged or advised to inculcate collaboration, emotional intelligence, and team building as part of their training. No wonder that statement, together, each achieves more, which is the short form acronym TEAM. On the other hand, because these three components are missing in training on the field, we tend to act and reason individually, professionally, not as a multidisciplinary group. When we think and act as a multidisciplinary group, it means that we will understand, or we tend to understand, or try to understand what the other person is saying, what they are thinking. And at the end of the day, I'm likely to shift from my present position, and we will cooperate, collaborate, and at the end of the day, things will work well. Now, the operating room is a mystery, and the level of research work happening there seems to be more on the scientific level. I'm talking about pure science now as it affects patient care. But little attention is paid to the human relations issues or part of the operating room. And I think that as researchers, we should turn our searchlights towards these areas. We're likely to see and find out reasons to what extent they are affecting the operating team, and how, you know, this can be better dealt with. We've talked about communication over and over again. Perioperative nurses, armed with emotional intelligence and proper understanding of communication, will, if communicating properly with the other team members, would go a long way to help in dealing with whatever situation comes up. However, I like to round up these comments by saying, if the perioperative nurses have emotional intelligence as part of their curriculum of training, it will go a long way to arming the periop nurses to deal with these social issues that operates or that are available or present in the operating room. And I think to a large extent, that would make us achieve a strong operating room where patient safety and successful surgeries will be carried out while the staff would be happy working with themselves. Thank you very much.
Thank you, Mr. Sunday. I think Dr. Nuguse has getting difficulty in network, and I will continue the next questions for our next speakers. So Mr. Kier and Dr. Khan will reflect on few questions, especially the remaining questions will be on how do you manage the tensions between team well-being and meeting demanding surgical targets or administrative expectations in our day-to-day activities? This will be for Mr. Kier. Can you hear me? Are you with us?
Yeah, I can hear you.
Okay, thank you very much. Share us your reflections. Thank you.
Okay, thank you so much. I would maybe bring this experience before I answer this question. This question is a little bit difficult. Me, like a nurse handling or being the unit head of a theater, managing the anesthesiologist, the anesthetist nurses, the surgeons. It has not been easy with me for the past years. And I don't know whether with other countries it's like the same experience I've had in Cameroon. We've had a lot of difficulties, especially in Bamenda Regional Hospital in our theater, where the anesthetists and the surgeons, they always have these fights. You know, a surgeon might want to bring a case, and an anesthesiologist will say, no, I don't want this case. We have to follow up if the patient is ready for operation. Meanwhile, they are just turning around with time because take place. And then you see also on the part of the surgeon, they might come, oh, this is an emergency. And there's always this problem of trying to differentiate with real emergency and an urgent case. So those are the type of difficulties we have been having. And you see surgeons, because of limit space, you see they come in the theater, they are fighting, they are quarreling. And at the end of the day, I will always look for ways to bring them together. And I'll tell them we are there because of the betterment of that patient. So what do we really do? What I do like a leader to bring them together or to curb down this tension, what I usually do is I always prioritize open communication, especially during our debriefing, where we discuss about the cases, our elective cases. I always try to talk to the surgeons and anesthesiologists. We should know we're here because of this common man who is our patient. And if the patient is not there, will not be there. It can be you, it can be me, it can be your father, it can be your husband, it can be your mother. So I always like try to like drill this down to your brain, and they always understand with me. And I'll say we just need to communicate and plan our cases, and we know who is coming in when. And what we do in Cameroon in Regional Hospital Bamenda, we have a lot of specialists, because that's a teaching hospital where we teach medical,
or it's from my
where we teach medical students. So what we do is this: we have shared the surgeon days according to the surgeons. So you know Monday is your day. Don't come to Tuesday when it's not your day. But you can come on Tuesday when it's an emergency. But when it's an elective case, you have to respect your surgery day. Now, another thing that we do is we set realistic goals, and what is all about that we ensure targets are achievable and align with team capabilities. We also foster a supportive environment by promoting work-life balance. We recognize burnout risks, and we provide resources for well-being. Like we have what we call prosthesis, where the surgeon, at the end of the day, you have something which you can say, if I'm doing this surgery, you're motivated, even with the nurses down to the cleaners. So that is how we have been trying to bring them together. And our director is having a very listening ear. He has promoted this prosthesis, where at the end of the month, the surgeon has something to go home, the nurses, the anesthesiologists, and the cleaners. In that way, I think we try to bring a unity among them. And another thing is we empower team members by delegating tasks. We provide autonomy and involve team members in decision making. We also monitor and adjust like regular assess team work, stress levels, and targets achieved. So like a leader, what I do is I lead by example, so I show that empathy, I understand other people. Maybe when a surgeon come in and say, oh, I have this emergency, the woman is bearing down, we need to operate this lady. And the anesthesiologist is like, no. It's not an emergency. You people like to turn around and give us work. I always go to the anesthesiologist and I tell them, it can be your wife, it can be your daughter, it can be your sister. And in that way, we try to bring down the tension. Another thing we do is like try to be flexible. And what do I mean by this? Adapt to changing circumstances and priorities. At times, you see somebody who come and say, this is my sister, this is my mother, we need to operate this patient first. And I always go to the surgeon, no, there's an emergency coming. We need to save this gunshot. The patient is bleeding. The woman is in labor. If we don't save her life and the baby will have a maternal death. And I said, your mother is not an emergency. Can we do that in an hour's time, in 2 hours' time? So that is how that is the way me, like a leader, I've been trying to bring down this tension among my the people working with me, the theater users. And then we also like seek for feedback. What we usually do, like, we get feedback from team members to identify area of improvement and where we went wrong. And this is always during our debriefing. We always like, during the last week, what did we do that was not good, or what did we do that was good or we needed to improve on? And people bring in their point and say, maybe you shouted at me when you talk to me in front of a patient, in front of students, in front of nurses. I don't like that. And we try to get everybody's differences. That is how, at my own level, that is in Cameroon, that is how I try to bring down the tension among the theater users. I think that is a little I can share with my own experience at Bamenda Regional Hospital, Cameroon. Thank you.
Thank you very much for clarifying what was raised and sharing your experience, your personal thoughts. And the next question for reflection is for Dr. Raza on to share your points on surgical technologists' efforts what are the opportunities exists for those professionals or surgical technologists to take a more active and decision supportive roles in enhancing intraoperative team working network.
Thank you, Mr. Siraj, from writing. So there are many opportunities exist for surgical technologists to take on more active decision support roles in teamwork. Like we discussed that the OR technologists that own the OR environment, they are stay in the OR environment, and they know the details of OR things, so they can support in the real-time decision making in the OR, in the crisis situation, through the situation analysis. So they can predict what instrument required. They can anticipate the critical events of the surgery. They can anticipate that what type of equipment, what type of surgical supplies, what type of can be required in this surgery. If there is any conflict between the instrument or the equipments, the clashes to surgery, so they can anticipate well before the time, and they can help us in decision supporting. They can also part of operative briefing and debriefing protocols. In this, they can help us to provide to identify the opportunities, the gaps between like the communication gap, the processes gap. So they can highlight these things because they actually know the facts, on ground realities. They can evaluate the instrument stats, equipments. They can anticipate the proposed breakdown in the instruments through the preventive maintenance and other things. They can redesign the OR flow, which help us the more efficient OR flow. Okay, and they can the OR technologist can also help the formal training and to the formal trainings of the newcomers to the ORs. That can be the surgical technology students, that can be the residents, that can be the medical officers, everyone. And they provide this support through like different surgical workshops, the leadership workshops, and other programs that impart the inclusion of such trainings. The OR technologists can empower them. Uh, it it can provide them the opportunity to share their opinion, and this can act as a respect element for them. Uh, so I feel that when surgical technologists are empowered, they contribute beyond just the handling of instrument. They become silent stabilizer of the entire intraoperative processes. Supporting them just they just not support the surgical hands of surgeon, but they are actually they can act in the cohesion of OR team. Thank you. Yes, Mr. Siraj. Can you hear me? One additional thing, which I would like to discuss. I think there is some connection issue with Mr. Siraj. So till he came back, the one Mr. Kimit discussed that the harmony in the OR is more essential. That can be achieved through effective communication, through defined intraoperative, preoperative, and postoperative defined surgical steps, process, and by another thing, that is the clarity of role, the shared responsibility of everyone to make the OR environment more cohesive, friendly, stress relief, and through the mutual respects. Thank you.
Thank you, Dr. Raza, for your nice explanations and the reflections regarding the operating surgical technologists on their advisable roles in making conducive teamwork in perioperative management. So lots of has been said by our respected panelists from various professions, as the URG is composed of professionals working in the operation theater for the safest outcome of patients. That's why we run for many to save one. So thank you very much for all of you. And I think Dr. Nuguse still is not with us because of bad internet connection. So I'm Siraj Ahmed from Ethiopia. So actually my role was to moderate question and answer discussion sessions phase now. So our CEO.
Hello, everyone. Thanks for connecting. Thanks for the insightful sessions. I think Mr. Siraj is having a network issue as well. It's understandable. There are things that we don't actually have control over. Amade Busola, CEO and founder of the Operating Room Global. I'm just going to continue this session, and to the end, we have just a few minutes. Let me quickly see if there are questions in the chat box for our panelists. I think I've seen that there are recommendations, there are comments on the session, which is really, really good. Someone said, I've learned so much from the three panelists. It's been an honor to be part of this. Thank you for your comments. Yes, and someone, I'm just trying to see if there are questions. There are comments, positive recommendations. Thank you so much for all your comments. Thank you for the well wishes. Okay, so there was a question from one of the participants on YouTube asking the panelists that regarding the mistakes or unpredicted problems in operations, who is to bear the effects and how? If in case, I really don't understand that. Maybe if in case there is a death, a sudden death or something, how do you handle this problem? Does the team leader only be in charge of everything, or what is the structure of the whole team? Is it possible for the team to operate while there is anyone missing? I think I'm going to ask Prof. Mokwa to respond to this question, if that is okay. And then all the other panelists can contribute to that if convenient. Thank you so much, Prof. You are welcome.
Thank you very much. Those are very important questions. First is the issue of who takes responsibility in the theater for the well-being or the life, at least the preservation of life for the patient. Now, let's make it very clear. This is teamwork. And so every person's contribution is very important. Each profession may have its own approach to this, but collectively, it becomes an ethical legal issue. So let's explain how it happens in practice, at least at this end, and what the regulations say in many countries. The primary responsibility for patient care is that of the surgeon in our case. That is a default setting. However, when there is such a situation where a patient dies intra-op, investigation is conducted. The pathologist comes in, interviews are conducted, forensics, all those things come in. At the end of the day, it may then be possible to specify who went wrong, who was not going in line with the collective or the procedure, the standard operating procedure used in theater. For example, if a drug was given and it was given overdose, all right, and the respiratory system shuts down, or oxygen was not administered for some time, then it becomes a problem. Then one can identify who did what in that situation. That's not to say that every other person is innocent. It is that it is then possible to identify where matters went wrong. If there are situations where there was, let's say, miscommunication from the beginning of the operation and all the way, and team members were not cooperating, were not collaborating properly, then other team members, other than the person in charge of the gas, may have to be found culpable in that matter. Such cases usually go to court. If, however, there is provision within the health hospital system to allow for the hospital itself to investigate and the different professional bodies to so investigate, in which case their tribunals may be involved, that's also another system or another way of going about it. But what's important here is that it should never happen. It should not even nearly happen. And that leads me, if you permit me, CEO, there's a question about timeout. I think this is linked to that. I might as well add that straight away, if you permit me.
Yes, please.
The importance of surgical timeout checklists is to prevent such things. I'm aware that there are concerns that in many situations, a surgeon might say, oh, it's a waste of time. Not necessary, we can skip it. It is when such risky decisions or such risky oversights are made that we run into problems. There must be, for example, clear verification that equipment and supplies are available. There must be verification that all team members necessary are on ground. The patient will be properly identified, the diagnosis properly identified. If you want to amputate, you know which limb is to be amputated. You don't amputate the wrong limb. All those things must be very, very clearly outlined so that everybody is on the same page. When that happens and infrastructural failure does not constitute a problem, death ought not to happen by far in most cases. That's my response to that.
Thank you so much, Prof. Moko Adeleye. Thank you for the insightful contribution. I believe that is clear enough and it's actually been answered. Thank you so much. There has to be roles defined and there has to be limits in what people do, even to professional level as well. Thank you so much for answering that question. I'm going to go into the chat box and see if there is another one. So I think this is from a theater manager point of view. What can be done when the theater manager and team leads do not prioritize staff and patient safety and make little or no effort to promote teamwork or staff motivation? Okay, this question is to Mr. Sunday. Thank you. Okay, I'm going to ask Mr. Sunday Ekwen, one of the panelists, to respond to this question, if that is okay. So from your view as a theater manager, as the head of a facility, what do you think can be the response to that? What can be done when theater managers and team leads, when they don't prioritize patient safety, staff safety, and make little or no effort to actually promote teamwork and staff motivation? Mr. Heckman, you are welcome.
Yes, good evening, everybody, once again. This is one big problem that we tend to find around us from time to time. It comes from basically the area of the level of understanding of the medical director, as it were, and the operating room manager. Now, operating room managers most times are appointed based on years of service or the extent to which they've been in practice. In today's world, that no longer holds. The extent to which you're knowledgeable in the trendy part of that professional subspecialty today becomes the criteria for actually selecting the theater managers. A theater manager who is current with patient safety issues, causes and reasons why patient safety is of paramount importance in the surgical care, will not put to levity issues surrounding patient safety. So from as it concerns the operating room manager, it may be necessary for recommendation of that manager for trainings. Trainings in different diverse areas as regards the person's deficiencies. Excluded from training needs. So if a viable training department is in that hospital, and this is a problem, especially where you have care assessments and other quality care indicators assessing groups and units, it will be obvious that something is wrong. And the manager can be assessed and at the end of the day, sent for training. Now, from the medical director's part, we will understand that the medical directors, most times, especially here in Nigeria, they wear two caps. First, they are the medical lead in the hospital, and on the other hand, they are as well the political lead in the hospital. That's why most times their titles are medical directors and CEOs. So they are the ability to balance the medical part and the administrative part becomes a problem. Most practitioners, I'm talking now from the point of having been a unionist and an advocate for perioperative nursing in this country, it's clear that one of the reasons why medical directors and managers of institutions handle issues of safety with levity is funding and fraud and every other thing that concerns corruption and all that. Now, poor funding means that you're going to have scarce resources. So, in the face of where we are, where whatever you are going to buy for whatever amount is either now made twice the price or thrice the price, as it were, you are not able to now fund major issues, and it now does not matter whether it is patient safety or patient comfort or whatever it is. So medical directors, in my opinion, should continue to lead hospitals, but I think that in addition to that medical qualification, the need for every medical director who manages a hospital to have a certification in administration is key. And if the operating room managers are sent for training if we're found, wanting, and the medical directors who pay deaf ears or levity to patient safety issues, even in the operating room, if they have a perfect blend of clinical and administrative roles, I'm not sure this would be. So this is my position as of today on this matter, especially with my experience from both the clinical and the administrative part of hospital management. Thank you very much.
Thank you so much, Mr. Sunday. Thank you for the insightful contribution. I believe that question has been answered. And there are other two questions that relate to timeouts. Those ones have been answered as well. There are some aspects that should actually be discussed at institution levels, and things should be escalated. Patient safety is priority, staff safety is priority, and there has to be debrief. I think that was emphasized at the beginning of the session as well. I'm just going to leave the floor open to one or two of the panelists if they want to just leave a comment, a final comment, maybe for 1 minute. If there is any of the panelists that would like to contribute or say anything, just to any remark.
Yeah, thank you. Yeah.
Yes, please.
I'll give remarks on both two issues in a quick run. The first one is in the event that there's a death, what do you do? I just want all of us to remember in the operating room, there are three very important people. There's the nurse who was in that surgery, there's the anesthesiologist or anesthetist, and there's the surgeon. So in my environment, the three leads of the teams, the person leading the surgical team, the anesthesia team, and the nurse, will go together to the bereaved family to break the news so that you avoid the blame culture. It was the anesthesiologist, it was the surgeon, until the medical legal issues around that death are properly investigated. So you break the news together, you don't run away. And two, the medical director and the operating theater nurse, I think it's a case by case. Normally at a lower level, as a staff in theater, you are very much buffered from the medical director because there'll be other sub-directors below that medical director that works directly with you. So problems begin when the medical director is not a surgeon and you expect them to reason like surgeons when they bring in their political things. And now when they start giving you targets that are not realistic for surgeons. And so that's where you need to sit with this medical director during the targets. They don't need to be surgeons, but they just need to understand that surgeons are not measured on how many cases they're doing. So you need to look at the matrices that you'll be using in the hospital to assess the progress of surgery and keep updating so that you are both understanding their perspective, their goal-oriented, and what are your goals. So when your goals conflict, then there'll be that conflict. And it goes back to communication. How do you communicate when your goals are conflicting? They will not be surgeons. The operating nurse will be understanding, will be pressured from goals as well. So you both need to stand together as operating team. The operating team must always be together, communicating, so that the medical director will understand what your goals are in contributing to his broader goals as the medical director. Thank you.
Thank you so much, Prof. Larry. Thank you for that contribution. Do we have anyone maybe from the audience, just one more person before we do the closing remark? If there is any one person, you can raise hand with the button. If you have a contribution, a comment, just a final comment. Anyone? I think in the absence of no one, time is now far spent. I must use this opportunity to say thank you. On behalf of the Operating Room Global TORG and the TORG Ethiopia chapter, I want to say thank you to everyone. Thank you for joining today's session, the session on building stronger surgical teams, unity in action. Thank you to our esteemed panelists from Nigeria to Tanzania to Cameroon to Pakistan. Thank you so much for your insightful comments. Thank you for your wisdom. Thank you for your dedication. Your reflections have actually powerfully demonstrated that unity in the operating room environment is not just a goal, it's a necessity. We've learned a lot. I've personally learned a lot. There has to be communication, there has to be collaboration, and Prof. Omokoa referenced the issue of the TORG. Just as we started TORG, that was 10 years ago. So the vision was, I wanted to go to another country. I wanted to see what was obtainable in other areas. I was online looking for this platform that can actually bring everyone together under the same umbrella. I can listen and listen to people from Canada, from another country, from different countries, and then I can see all the evidences, see the cost of living and everything, compare and contrast, and then decide. There was zero platform like that. So that was the foundation then. That was how we started 10 years ago. And then I discussed with the co-founder, and who happened to be my husband. And it was like, since there is no platform like this, why don't we just start it, collaborate with others? By the time we started opening social media channels and everything, we discovered that same gap was basically in every country. There was no platform like that, bringing operating room professionals together, having discussions, weighing things around. And even if people could notice, on the platform, we see members most times, they want to share what is going on in their operating room environment. They actually want to see responses from the other countries and see, oh, is this thing in alignment with what is right? Or do people do this differently in another part of the world? That is why those posts keep going on and on and on. So that was the reason behind TORG. Collaboration, communication. There has to be limits. Everyone, you are a boss in your own right. And for patient safety to be effective, everyone has a role to play. You have a role to play. I have a role to play. You don't depend on someone to do what you are meant to do. Because, you know, in the operating room environment, everyone comes together to decide on a patient. On lots of the other units, like on the wards, you could get maybe 5 professionals. You could get maybe, for example, from perioperative nursing aspect, maybe on the surgical wards, you could get a nurse looking after 5 patients, after 10 patients, after 15 patients, depending on your facility. But in the operating room environment, there is only one patient at a time, and multiple professionals have to decide on that patient. Now, when the patient is under anesthesia, you know, it's more risky because that patient can no longer speak for himself or herself. You have to be the voice of the patient. Whatever you do can determine if this person is going to leave, if this person is going to survive or recover from whatever they are passing through. So that is why this is actually very, very important. And I want to say to our audience, thank you for your active participation. Thank you for your engagement. A special thank you to the collaborating institutions, to the fellow, to the TORG fellow, that's medical student Samuel Fodop, that actually organized this, that put all of this. It was the brain behind the topic. It was the brain behind the idea. It was the one that actually said, let's do this, and collaborated with the chapter and made it happen. So I want to say thank you to our fellow Samuel Fodop. I want to say thank you to the collaborating institutions, the Cameroonian Medical Students Association, that's CAMSA, Incision Cameroon, Cameroon Nurses Association. Thank you for your support. Thank you for your partnership. Thank you for making this to happen. I want to suggest to everyone, let's carry forward the energy. It's not just about just discussing now. You have to go back to your facility, discuss with your team. Everyone here, you're a boss in your own right. We have heard that time and time again. Go back to your facility. Make sure you be the change that you actually want to see. Lead that change. Do that thing. If they are not respecting the surgical safety checklist, organize a session, organize a workshop. If you want TORG to collaborate with your facility, we can do that. We've got so many faculties, so many experts in their fields. They can collaborate, they can discuss, they can meet with your faculty, either online or in person if you want, and they can make the change happen. So I want to say thank you, everyone. Once again, Prof. Omokoa was in a conference last year in Nigeria. It was really, really insightful. It was supportive. Thank you so much, Prof. And I hope to see you again in another session. I think Prof. Larry, we were on the same panel at the Pan-African Conference in Kigali. That was in February this year. And I learned a lot from him personally as well. Thank you to everyone, all our leaders. Dr. Raza Khan is the chair of the Pakistan chapter. Dr. Leonid, Dr. Daya, we hope that you are going to join us. Thank you so much. And Mrs. Kiye, I think that aspect that you mentioned on motivation, I don't know how you made that happen. I think you will still have to speak to it, our community, because it doesn't happen in any facility. I've never seen someone mention that, where a facility, the leaders would have listening ears, they would motivate their team members. At the end of the month, the surgeon will be happy, the nurses will be happy. Sorry, that is new, completely new to me. So maybe you tell us more about what you have done and step by step on how other facilities can actually implement that. So thank you for bringing that up. I want to say thank you to everyone. Thank you to all our leaders for facilitating this. Dr. Nigusi, Mr. Siraj. Mr. Siraj is a PhD fellow, is the president of the Anesthetists Association in Ethiopia. I hope I'm correct. Thank you so much. I want to say thank you to everyone who connected, for taking the time out of time even to connect. I could see Dr. Atali is connected. Mr. Wilson is connected, is the director of the Talk Global Education and Training. I could see all our leaders from Diverse Field. Dr. Gloria is the secretary of the chapter. Thank you for connecting. Dr. Elnara, she's an anesthesiologist from Kazakhstan. I'm not sure what the time is at your end. Thank you for connecting. I could see so many. My apologies if I can't mention your name. Thank you to everyone. And the next webinar session, I think we have one with the new initiative of TORG, which is the Talk Journal, how to publish with success. So it's in 2 weeks, first week of August, and we are going to announce that across our platform. So thank you, everyone. The evaluation and certification link has been dropped in your chat box. Either you are a member or not, just make sure you have that form filled so that you can receive your certificate. It's accredited with 2 CPD points. And I want to say thank you to everyone for joining tonight. And depending on your time zone, good morning, good evening, and good night. And hopefully we'll see you again. Bye, everyone. Bye. Thank you so much.
Bye. Thank you.
Bye.
Good job.
Thank you. Bye.
Good night.